Okay, actually, I took this, I modified this presentation that I had been giving, early this year for PCR, for a webinar PCR, and we were discussing about actually this, the expanding horizon, because it was basically related to the change in the guidelines. We were saying, okay, now what's next? What's next, considering how far we have been with the practical use of DCB compared to the indication from the guidelines. So I just want to show you what I do, which is not necessarily correct or applicable in your practice, but then these are the common indications of DCBs in my practice. The hybrid approach, which is you've seen multiple times in these 2 days. ISR, I have to say, and then that's fully on my shoulders, I do not place another stent for ISR. I'm sorry, guidelines are clear-cut. I don't use another stent because I think it makes little sense to me. Unless, there are a few cases where it's meaningful, unless it's a very tight edge restenosis involving proximal or distal segment to the stent. Okay, that makes sense. Otherwise, if it's diffuse inside the stent, I will never put another stent. Small vessel disease, I basically do not use small stents. Side branches, I try as much as possible to use a DCB. When I'm doing POBA, when I decide to do the POBA or the kissing balloon, I always use drug-coated balloon. CTO, as you see, the piece of this cake is relatively small because that's the percentage of CTOs in my activity, which is honestly something I really like, but not that much. Large vessel is the smallest piece of the cake, and this is because, of course, in a 4 or 4-5 artery, DES will perform very well. So still we don't have enough data to support this transition, okay? And by the way, we are not discussing that DCB is against DES, okay? No one here is against DES. We are just trying to understand the true combination and integration. Calcified fibrotic lesion, of course, and definitely HBR, okay? This is what I do. I will disclose immediately in patients with HBR, hybrid in risk patients, where I use DCB only. I just give dual antiplatelet therapy for 2 weeks, which is far away from the guidelines, but that's what I do, indeed, my practice. So let's start with some cases that was calcified, fibrotic, and HBR. So this gentleman was relatively old with the recent diagnosis of non-STEMI diabetic patients with renal failure. So as you can see, tight lesion on the RCA with a lot of fibrosis, probably a minimal amount of calcium. So what I have done in this case, immediately rota, with some resistance, as you can see here, so I had to adjust, the position of the catheter, the wire, and so forth. Then, physiology. Because in this case, I just wanted to make sure that I made the job with rota, and I did. So I said, okay, there's no point to keep going. I will use DCB to finish the procedure, and it was 0.95. Remember that this kind of approach, rota plus DCB, it's pretty straightforward, because as long as with rota you don't end up in a huge dissection, which is really rare, with the DCB you make sure that you basically deliver the drug. No stent needed, and that was the final result. Nothing left behind. CTO, distal non-occluded segment, this is a very complex procedure I've done more or less a year ago. It was the anti-grade approach. Just skipping a few steps because this is not CTO setting today. So, through the septals, I was trying to get to distal circumflex. It was not possible, even with a ping pong technique and reverse carte, everything failed. So it was a bit of a problem. So I had to change my mind multiple ways. At some point, I managed to put down a stent, okay, because it was completely destroyed, and I skipped the angio where I perforated. But trust me, it was perforated at some point. So I placed the stent, and everything was absolutely under control, except that the distal portion was like that. So in my mind, it was just no way to place another stent. No way. So I said, okay, nice. I will place balloon, and that was the final result. Absolutely acceptable. Okay. Again, I skipped all the steps for CTOs, but forget it. The point is, distal segment after CTO, to me, to my practice, is a very nice candidate for DCB, because the artery will get bigger, so we will not have the problem of underexpanded or malapose stent. You deliver the therapy, you deliver the drug, and you give time to the artery to recover. Side branches. So left main, but the disease was mostly involving LCX and ramus. So just keep the concept of one stent, two stents, whatever. So I basically did a two-stent technique here for the left main LAD, LCX. Ramus was impaired, well, badly at some point, but I didn't care. What I do care in these situations is to have a wire down and a very nice, well-expanded, long DCB to get this very nice final result, okay? We can discuss, of course, about one stent, two stent, but this is not the topic for today. Just remember, when you have the opportunity to combine DES and DCB for side branches, just consider it all the time. Again, a CTO and small vessels, so that was right. So I was negotiating. It was not that easy because, you know, the antegrade attempt with the fine cross and field was basically not successful. I had to do a subintimal tracking, but I don't really care about that. So antegrade wire escalation, like Gaia 2, so I get to the distal cap negotiation. Now I'm not showing you the imaging that I've done, because I've done the OCT in this case. Multiple predilatation, drug-eluting stent. That stage was not so good distally, so it was, again, and no way for an additional DES down there. DCB, and that was the final result, okay? Truly acceptable. So, large vessel and HBR. This lady came in with 3-vessel disease and with a misdiagnosed anterior STEMI, apical thrombus, so definitely HBR, and a mandate to triple therapy. No way. Large anterior scar with thrombus. Okay, so look at that circumflex. So I started preparing everything, multiple balloons, semi-compliant, non-compliant, and cutting in this case because it was some kind of resistance. And then there was the final results with the DCBs. So just to summarize, it was really a brief excursion and list of cases that I am collecting. Everyone has his own practice, determined by the availability of devices, experience in using different devices, but also, I would say, personal approach to treat diseases. I'm not very dogmatic, I'm not at all. But I will also say that challenge yourself, because the DCBs now are an opportunity to do what we're doing even better. It depends on multiple things, multiple considerations, of course, but then the real message I want to deliver is every time that you have a lesion preparation to do, just think about that PCI doesn't mean DES implantation. PCI means fixing the coronary stenosis, thinking about acute and long-term results. Okay? Thank you very much, guys. And Paolo, please come and join.